Well, this is very kind of you. I'm not, certainly not the best, but I'll try to explain some things when it comes to the topic of imaging, not only MRI. Obviously, I will focus on axial imaging. Yeah? And you may see that I will be skipping some slides. I will put a little bit more effort on some other slides. What I have put together here for the next more than 1 hour is the approach to imaging in axial SPA. And again, imaging and the current status still says, and that is the important thing about imaging, that we should be using X-rays. You know, everybody's doing X-rays in everyday practice. It would be nice to know, although we are a very large room and very large group here, it would be nice to know who of you are not doing any X-rays anymore. We're still doing it. Yeah? So the question is, how would we apply the X-rays? One thing that and some things are easy, I will therefore just mention them briefly, you always take into account is, and that's the current status, where does the patient have the pain? If you have pain in your lumbar spine, you do the sacroiliac joints and the lumbar spine. If you have pain in your hips, you do the sacroiliac joints and the pelvic X-ray. We know, by the way, that sacroiliac joints and hips are related, and the hips, if they are involved, especially in younger patients, we have a more severe disease later. So it's recommended that you always test the hips. And when we look into the sacroiliac joint itself, the way that we assess X-rays and MRIs is very similar. We know that there is different layers from the top to the bottom, and we have, we have areas with more and less cartilage. So in fact, what we are doing is that we look into the X-ray, and this is now the front, that's the back, and when you do the X-ray examination, you'll see one ray going through the entire sacroiliac joint. And that obviously is not good enough because you may have the cartilage, but you also may have the soft tissues, which in fact brings us to the point that we have, especially when we do not have the right tilt in the sacroiliac joint, we also do not really see the three important parts, which is the upper, the mid, and the lower part. The most important of them is the middle part. This is where you have most cartilage. So it's important, again, that we image the sacroiliac joint properly, and it makes sense to rotate the tube to the cranial area so that you look into the sacroiliac joint as much as possible, capturing the cartilage. Now, I will start with the X-rays. Again, it's relatively easy to know these things, but we will take that knowledge later to the MRI. And remember that we have to pay attention to two things. First of all, the lines of the joint, and secondly, the width of the joint. They need to be as if you take a pen and you go alongside the cartilage line. In a patient who has sacroiliitis or structural changes, you see this line is disrupted, and that width is also widened or narrowed, which is typical for spondyloarthritis. This is important because we may have patients with back pain who come with even inflammatory back pain, and we do an X-ray and we don't really know how to read it. And it's always easier, if you make yourself easier if you just really try to see if those lines are straight or not. Now, these things here do not really help a lot. Yeah? This is something we know from the modified New York criteria. It was used, the grading, bilateral grade 2 or unilateral grade 3 or 4 means spondyloarthritis. In daily practice, again, what we're doing is we look into the normal cartilage line or to that line that has this kind of disruptions, like this one. Yeah? So this is the typical marginal eroded joint with the widening or the shortening of the joint width, and of course you have the subspondylar sclerosis. So all this is not only an X-ray sign, it's an MRI sign as well. So I use these slides for my MRI workshops or the imaging workshops. We cannot really discuss things right now, but I will try to go you through or drive you through these images. This is a symmetric bilateral involvement, either with shortening of the width or with widening of the joint, with sclerosis, with erosion. This is typical for spondyloarthritis. And by the way, that's a spoiler for later. The reason that you see the erosion here is because this erosion is very large. But there might also be smaller erosions that you do not see on the X-ray. You remember, because you send the X-ray, the ray through the joint, and therefore you have a lot of overlay. You may also have unilateral involvement. There are specific conditions that we may see this, mainly in psoriatic arthritis, reactive arthritis, but also in areas where we have inflammation because of, let's say, bacterial inflammation or tuberculosis, typically. Yeah? That would be something like this. And you may also have this kind of thing, where you have a lot of sclerosis, bilateral or unilateral, in a triangle form. And if I now ask you, can you imagine what that is? It's a typical osteitis condensans finding. Yeah? You have a bilateral involvement, it's symmetric, but, well, here we cannot see it, but it doesn't really affect the line of the joint. Yeah? It doesn't really widen it much. So it's a typical osteitis condensans. The problem with X-rays is that they are not always showing everything properly. You may see that patient where you see the lines nicely. There's not big change in the width of the joint. However, if you see that patient, you will see that probably, or as a whole, you will see that he has a complete ankylosis of the spine. So this is a complete bamboo spine. And the problem with that one is that the osteoporotic bone doesn't allow you to obviously judge on these lines very much. So it changes from very important to less important, what I showed you, this rule, the more severe the patients become. Now, one thing you need to also take into account is that you need a radiologist who does the X-rays properly. And it is recommended that you always use the same 2 or 3 radiologists, because then you can also compare the images of the patient over time. You remember I spoke about angulation? Here you see one and the same patient on the same day. This X-ray was done without angulation, directly standing position. This is now with a 10-degree angulation in a lying position. And you see that you already see a difference in the width of the joint. Now, this is not pathologic, but I just want to tell you the way the X-ray is being done is important. Yeah? You may also see this case, another patient, same day. On those X-rays, you don't really see much. But if you do the X-ray towards the right or towards the left sacroiliac joint, you see how many erosions, also here, and changes in the width of the joint you may see. So it's important that the X-rays are being done properly. And that is because, again, when we're stunned, it's different on the MRI, but when we stand, we see the sacroiliac joints like this. Usually, or normally, they go like this. Yeah, this is a 3D reconstruction we've done, and I took the images of a CT of a patient who came with back pain. Here you see how this width will change. I go back. So the sacroiliac joint itself enlarges or decreases its width based on how the patient is lying on the bench. One other thing we need to take into account is that we may have different lines that we see on that sacroiliac joint. And again, I'm not wasting our time with X-rays now. I'm using this for showing the MRIs later. So the question is, are you looking into this, or are you looking into this line here? Yeah, the same here. Is that the line you're looking at, or is this the line you're looking at? what is the sacroiliac joint? In fact, it is both, yeah. But we're looking into the entire joint and not only in the one or in the other line. Of course, the posterior portion has lesser importance because there is more soft tissue. The anterior and the middle portion is more important because it has more cartilage. Now let's have a look at this case. The one or the other person in the room may have seen that. I'm not really sure because I show you this. It's a nice case to take into account when you talk about how X-rays and MRIs complement each other and what the correct performance of the imaging may show us as a result. This is a male person. He was 28 years old when I saw him, had inflammatory back pain, no CRP, no B27, and he had some heel pain. And the general practitioner sent him to us because he gave him the diagnosis of ankylosing spondylitis. Why? Because this sacroiliac joint here looks pathologic. Yeah. So the heel was okay. There was nothing to see. There was just some tenderness. I didn't really put much weight on this. He was doing some sports, but otherwise he was healthy. And then, of course, we went on to do an MRI, and this is what we saw. Nothing. So the question is, where does that sacroiliac joint damage come from in an otherwise healthy person? Well, the problem is, as I mentioned before, the problem is how you do the X-ray. That person was having his X-rays done in a standing position, and you see already here there is a discrepancy of the length of the legs, which makes the tilt different. This means the right sacroiliac joint comes to the front, and that's why you have an overlay. This is a totally normal joint, but the X-ray doesn't show you what is happening. So it's overall depending on what are the symptoms, how old is the patient, how did you do the X-ray. In a 35-year-old patient with inflammatory back pain, it's different, that sacroiliac joint, or that one, as compared to a 60-plus-year-old person with no inflammatory back pain, chronic back pain, and no really typical symptoms or findings. This might be erosive but degenerative in the older person, 70-plus if you want to say, and this is obviously both strongly pathologic in a younger person with inflammatory symptoms. So overall, you may have different issues, you may have different diseases, you may have different reasons to have, obviously, unilateral, bilateral, symmetric, or asymmetric findings or changes in the sacroiliac joints, and especially when it comes to the joint space, there's also different reasons to know that there is a lot of diseases that affect the sacroiliac joints. It's not only sacroiliitis and spondyloarthritis. Now, we will use that later for the MRIs. Let's go shortly to the conventional X-rays of the spine. And the question is now, what do we see on this X-ray? And what is pathologic? What is the so-called shiny corner? I can tell you that that shiny corner term is only relating to the X-rays. So if somebody says shiny corner on MRI, that's wrong. It's hyper intense in the MRI. But the shiny corner of the MRI are these white spots. I will show you the lesions on the MRI later. Remember that the white spots on the X-ray are sclerosis. And sclerosis on the MRI is black. Yeah? So it's white on X-ray, black on MRI. Therefore, it cannot be a shiny corner. Yeah? Now, hyperdensity, this means white spots on the X-ray. Which of them are pathologic and which are not? They are all around the corner. They are all white and they're all small. These small lesions are important for us in spondyloarthritis. However, we need to understand that there is differences in how these lesions may look like and why they come from, where they come from. Here, let's start with this one. This is a clear, shiny corner. This is sclerosis with an erosion, okay? It's at the edge. That's the same. That's the same. Here we have an overlay of the pelvis. However, that corner is even more hyperdense. Sorry, it's very low. I understand that some of you may not see that. The difference from this very low corner to that corner, which is not spondyloarthritis related, is that here we have that hyperdensity directly there where the rib is going along. Okay? Here we have the pelvis, and there is a higher density anyway in the lower part. So altogether, pay attention. That's the main essence of this slide. We look at the edges. We look at white spots. We look at hyperdense lesions, maybe with or without erosion. But especially there in the upper part of the lumbar spine where you have the ribs, there is a lot of bias, there is a lot of false positive findings because of the overlay of the ribs. Now, there's the other thing that we pay attention at, and this is the squaring of the vertebrae. Squaring doesn't mean that this is a squared vertebra. It means that you have a line that squares the anterior part. Yeah? That's a squaring. You don't see that here. You see that here. So it's the first sign of new bone formation. Still, if you want to think a little bit about this case, this patient has advanced ankylosing spondylitis. We don't have the sacroiliac joint, we don't have a single syndesmophyte, or maybe we have a syndesmophyte, a small one. This patient has advanced ankylosing spondylitis. Why? Because there is different areas where the disease will go. Mainly it starts in the sacroiliac joints. Mainly it does also syndesmophytes. But there is no other disease in the world that really will fuse your facet joints that much. Yeah? So this is a bamboo, this patient cannot move. Yeah, he's completely fused. We have a posterior syndesmophyte, but that's just one of them, it doesn't really matter. You have some squaring, you may have also here, I will go back, a little syndesmophyte starting forming, but the most important thing is the facet joints. And that is the difference between classification criteria, the ASAS classification criteria, and diagnosis. The classification criteria do not capture this patient. Yeah? But this is a clear diagnostic sign. And then we have those patients who have, and this is an older X-ray, the quality is not very good, but you still can see nicely, there is a lot of facet joint involvement, no syndesmophytes, or that's a typical finding with new bone formation here, here, and facet joint involvement, and also some ossification of the disc. That's more advanced. How do we differentiate between the syndesmophyte and the spondylophyte? The degree is important, so if you have something that is really going from the top to the bottom, this is more spondyloarthritis related. If you have something that is going more horizontal, like this is more degenerative. And you can, of course, have both in a patient. So that's, in fact, the final stage. One important thing is to differentiate between the other important disease that is causing new bone formation, that is DISH. And the important difference here is that in spondyloarthritis, you have more thin syndesmophytes. In DISH, you have more thick osteophytes. Yeah? So they are really going more circle, and they are thicker. It seems that they are running alongside the anterior longitudinal ligament, or here you can see that nicely. Whereas in spondyloarthritis, you really have the connection between the two segments. Yeah. And in PSA, we have something in between. I'm just bringing this up because if we have axial involvement of psoriatic arthritis, they're also bridging, but they look like this. If that patient has psoriasis, then I would rather call it involvement of the spine in PSA. But sometimes these patients have also metabolic syndrome. They're overweight, they have hypertonia, they have diabetes, and then you may have this and psoriatic arthritis. Yeah, it's always a mixture. It doesn't have to be black and white. Now, other reasons to have back pain, I will just show them relatively fast. This is mainly the degenerative changes, such as spondylolisthesis and spondylolysis. You have the lysis or the lysis here, where you have that sign of a fracture. And you have the anterolisthesis, where it goes to the front. This is slipping to the front or to the back. Yeah? And we have also that grading. You may have heard that myadine grading, it's called, in 4 different similar portions of the lower part of the segment. I'm just mentioning it in case you've heard that. It's not so important here. Now, we also spoke about pitfalls, and that presentation is about pitfalls, and sometimes you have the pitfall that the patient causes the problem in terms of his or her posture, especially in those who are like this or do have back or neck pain. You may not even be able to really see the entire cervical spine. Yeah? Or in obese patients, you may not be able to really see everything. I skip that one. One important thing to remember is that there might be this kind of changes as compared to those changes here. This is the same patient after almost 2 years. That is a typical syndesmophyte. And this is a typical bone formation within the ligament. Yeah. The radiologists call it spondylosis. In fact, it's just ossification of the ligament. It doesn't mean anything. It doesn't hurt. It doesn't cause you any functional impairment. Now let's go over to MRIs, and I will try to give you the pitfalls and also the correct way of looking at it, very briefly, of course, due to the time. And remember, we have 2 important things here. We have inflammation, and we have post-inflammatory lesions. Post-inflammatory lesions are fat and erosions, mostly fat in the spine. Yeah? When inflammation goes away, fat comes in. And that will lead later to new bone formation. That's the continuum. Now, very briefly, the sequences for the MRI. In the field of spondyloarthritis, we're using T1 and STIR sequences. I will show you why we do not use gadolinium. And we differentiate them because the STIR sequences are more important for the fluid, and the T1 weighted images are more important for the fat. So in fact, if you have an inflammatory lesion, it has the same intensity. Now we speak about intensity, not about density. Density is for X-rays, intensity is for MRIs. Here we have the hyperintensity, the same signal, white signal as it is in the fluid. And for the post-inflammatory fat, we have white signal as it is for the fat. And there is a lot of other information you can get from those MRIs. And what you can see is that, in fact, T2, plain T2 images do not really help us because they're all white. There might be that you can get the fat out of the T2 sequences by the protocol of the MRI. Well, that is not being done anymore. Sometimes you may see those images. Yeah? And the gadolinium images, they're also good because they're showing inflammation. Yeah? It's positive here. But it requires more time. You give the gadolinium, the injected gadolinium, it's more costly. It is obviously also having adverse events. The STIR and the T1 images are good enough. Now, how does it look like? First of all, you have to look at the areas where you have fluid. If you don't have fluid in the cerebrospinal fluid area, then it's typically a T1 sequence. If you do have fluid, then you go further and ask if you have a T2 or a STIR sequence. The T2, I remind you, shows fluid and fat. The STIR shows fluid but no fat. So this one and this one are the most important ones. Here we see the inflammation because that's the normal bone marrow. It's gray. If it is white, the same as the water, this needs to be, or this must be inflammation. This is now the T1. There is no water, there is fat. That's the normal bone marrow. If you have white spots, well, you have them because the T1 sequence shows the fat. So it's a fat within the bone. This is old inflammation. That's fatty degeneration. So T1 and STIR. For the gadoliniums, you do see the edema again, but I will leave out the gadolinium sequences for now. We can discuss later if you're doing them and why we could do them. STIR and T1 are the most important ones. For the sacroiliac joints, we know that we want to look at them in a three-dimensional way, and we cross the slices. We call them coronal and axial. Actually, we call them semicoronal and semiaxial because they are not coronal and they're not axial. They have a tilt in the magnet, in the tube, okay, in the coil. And this is why they are semicoronal and semiaxial. Semicoronal and semiaxial. So the other thing is the slice orientation, the slice thickness. You may know that there is slices that we are cutting out of the patient on the MRI. The thicker the slice, the more blurry the image, but the faster the examination. The thinner the slice is, the more sensitive the image is. So maybe you also get wrong information because of a vessel. And the longer the examination is taking place. So if you have a 1 millimeter or 3 millimeter slices, it's a big difference. Usually we use 3 millimeter slices for the normal MRIs. That's what every radiologist should do. And what we are looking for is typically, again, on the STIR sequence, the edema, which is white on the STIR and black on the T1 image. Or we look for the white lesions on T1, it's fat, and it's black on STIR. So they are complementary. So again, that's how it looks like on the MRI of the sacroiliac joint. We cut it from the front to the back, and we're looking like this, into the image like this. So we are slicing and going through the slices like this, and you know it. This is typical edema, there where the cartilage is. One important thing to take into account is that there is a point in time where the sacrum has its curvature here, so it misses some cartilage. This is that part, which is not an erosion. This is where the ligaments come in. Yeah? So this is a normal S-shaped sacrum. The iliac part, the iliac bone doesn't have that. Yeah? And then we go further to the back. If we look at the axial or semi-axial orientation at the same patient, we see the edema, and then obviously we can cross the images and get a three-dimensional approach. That's a typical standard for the sacroiliac joint. Semicoronal orientation, T1, STIR, slice thickness 3 to 4 millimeters. Same thing for the spine, sagittal orientation, yeah. Slice thickness 3 to 4 millimeters, T1 and STIR as sequences. One thing that I would like to suggest, and I'm using this slide now for a couple of years because I think it makes sense to really also take it for your clinical practice. there are patients who come either to the rheumatologist or to the orthopedic practice, and they complain about back pain. The typical protocol for back pain for the radiologist is sagittal images of the lumbar spine in T1 and T2 sequences. There's many reasons for that. Mainly it is because the orthopedics use mainly the T2 for anatomical reasons. It is much clearer, the picture you get, for all those structures that they are interested in. And obviously, you can still see some water, you can still see no water, and so they can work with that. Now, what we have implemented at our center is that all these patients who come with doesn't have to be inflammatory, but chronic back pain, and they're below 45 years of age, they automatically get also a STEER coronal image. So it doesn't need to be tilted, it doesn't need to be anything different. A very brief screening with, let's say, even 4.5 or 6 millimeters in order to look into the sacroiliac joints. And you see this is the same patient. There is nothing to see in the spine, but the sacroiliac joint on the left side is massively inflamed. And that patient needs then to go to the rheumatologist. So as a screening procedure, it makes sense to ask your radiologist to do that sequence. It really takes 2 minutes. It's very, very fast. Now, what do we see and what we do not see with gadolinium? You see that here. We see osteitis with STEER and gadolinium images. We see synovitis. We do not see capsulitis with the STEER sequences. We see that much better with gadolinium, but again, we're looking into the bone marrow edema mainly, and this is why STEER sequences are good enough. And now let's say for the record, you may see spondylitis in the front, in the back. You may see facet joint involvement only. There is many different things we will see in those MRIs, and all of them count as positive images or lesions for spondyloarthritis if the symptoms are correct. We heard that also in the previous presentations for both the MRI and the periphery. We need to see these lesions in the context of the symptoms. Now, once we have the standard, we can go and discuss problems and pitfalls. And this, I believe, was shown before. It's about whether or not you may see false positive lesions in the normal population. This is a Belgian study. I may be repeating now what was said with military recruits who went on a long march, and they took an MRI of the sacroiliac joints of those otherwise healthy people, young people. And they found edema both directly after the march, but also 6 weeks after that. So the bone marrow edema is there even if you're healthy. It's a sign of stress. And in the Dutch study, they had patients with spondyloarthritis, but they also had patients with chronic back pain, women after pregnancy, frequent runners, or even healthy volunteers. And you see in the healthy volunteers, 1 out of 5 has edema. We were able to have a study, I think I'm not showing the slides now, in Germany, where we took 800 healthy individuals. All of them, they were below 45 years. Men and women had the same amount, the same prevalence of bone marrow edema in the sacroiliac joints. None of them has spondyloarthritis, and this was similar to that. It was 18 or 20%. So if we take those here below 45, I'm not counting there, and we put you in an MRI, 1 out of 5 will have bone marrow edema, which is a problem because then this might be misinterpreted as spondyloarthritis if you don't put it in a context of symptoms. So how would you then differentiate? the normal bone marrow edema. The normal means the spondyloarthritis-related bone marrow edema from the false positive. Here are two examples. First of all, you look on where you are at. If you're in the very front of the joint and in the lower part, this is not counting as positive for spondyloarthritis. Here you see you are in the very front because that's the bowel, that's the semi-axial image, and you see the edema is here in the very front and in the lower part of the joint. There is only sclerosis. You remember this is white on the X-ray. Triangular form, that's a typical picture of a patient, of a female patient with osteitis condensans, even if there is edema. Similar thing here, where you differentiate between axial spondyloarthritis and bone stress. Spondyloarthritis-related edema has a large extent, it's a lot. It's in the middle of the joint, and it's really very bright. You see that here, it's in the middle of the joint. Very bright, a large extent. Bone stress, like that patient here, or this patient here, is smaller, most of the times, lesser intense, and it's always in the front. Here is the bowel. The images are now turned around. This is the bowel, and this is really there where the ligaments pull. Yeah? So that's why this is not SPA, this is SPA. So this is the anatomical part of it. You see, if you have that here in the upper part or in the very front, it's a little bit difficult to differentiate. Here the ligaments pull on the bone, and then you get the edema. You remember I asked also before, is it an enthesetic problem or is it a bone marrow edema issue? If you have an enthesis, it may also really pull on the bone and it causes you bone marrow edema. This is not SPA. Yeah? This here is far away from the bone and from the cartilage. It's very little. This is the area you're interested in. This is not the area you're interested in. This is a typical cyst or a typical enthesetic lesion. And that's the same patient. Even for the structural changes, that fat is away from the joint, and it's also not really very clearly marcated. It's demarcated. So in fact, that patient does not have spondyloarthritis, although there is bone marrow edema and there is fat. So I showed you these kind of things before. If we go into some one or two cases again, and you look into this female 46-year-old B27 patient, positive patient, with chronic back pain. So she's 46, she's female, has back pain now for many years, and is B27 positive. And the X-ray is positive, with sclerosis on both sides. CRP was negative, and we did the MRI. Although I believe many of you may have said, well, that is typical osteitis condensans, looking at the MRIs may confuse you. That's the stereo, that's the T1 sequence. Why is it still osteitis condensans? Because the edema, although it's now a little bit larger, the edema is in the lower part. I don't have the axial images, but you can see that here there's only bowel, there's not much of bone. So it's in the anterior part also. And for the T1 sequences, I hope you can see that properly from the back. You remember the lines that we were putting with our pencil. The lines are perfect. There is no erosion, there is no fat. And the white part on the X-ray is black on the MRI. It's hyperdensity, it's sclerosis. Sclerosis is the typical part of osteitis condensans. Why do you see a lot of edema here and a lot of sclerosis here? I'll try to stop the presentation. You remember? We have different thickness of the cartilage. Yeah? The iliac part has a thinner cartilage. The sacral part has a thicker cartilage. That is a mechanism of defense for the bone. This is why you see, let me go through it, hold on, 1 second. This is why we see the most of the lesions in the iliac part, in the iliac bone, and only later, if at all, we see them in the sacrum. Yeah, this is much better preserved. The sacrum is lesser well preserved because here the cartilage is thinner. Okay? So let's move on. Where are we? Here. Okay. Now we have 3 different slices of a CT of a patient. And what we see is that there are differences in the joints. The joint is ankylosed. The capsule is ankylosed. This is a typical finding of osteoarthritis, a typical finding of degenerative change because it's really a round shape, it's not straight. You remember the same is the thing also for dish. And the problem with this part of the ankylosed joint is that that patient was relatively old in terms of having now maybe even inflammatory back pain. In any case, we know that this is a process of aging to develop more bone as well. And this is why that ankylosis is an ankylosis, but it doesn't have to do anything with spondyloarthritis. Now, those of you who may want to think a little bit, I give you 10 seconds. And you have to think about those 3 different patients. What are the diagnoses and why? We have different findings on the joints. We have a lot of sclerosis, but well-preserved joint lines. We have some sclerosis, but some changes that go like this. You remember we found that before. And we also have some sclerosis, but a lot of erosions in the cartilage. These are the findings that, of course, you have a patient in front of you always, and you have the symptoms and you have the lab. But based on imaging, where you will make different diagnoses. Yeah? Here you see there's only sclerosis, the joint line is fine, the joint space is okay. Here the same, but with a typical osteoarthritic change. And here you have a typical sclerosis, erosion, local osteoporosis, and also some joint space changes here, for example. Yeah? And you may have that patient who has everything. He has triangular sclerotic changes, has some starting osteophytes, and also has erosions in the bone. Who can be an AS patient with osteoarthritis on the condensans and degenerative changes. In fact, this is a typical case of ankylosing spondylitis. Okay? So pay attention. In X-rays, the same for CTs, the same for MRIs. The joint line and the joint space are important. Now we have this patient. Female, 47 years, chronic back pain since 25, 27 years of age, HLA-B27 positive, some sclerosis, some erosions, unilateral, and the MRI, I didn't have any better images now because it's a PowerPoint, I cannot scroll through it, but you see that here there is some edema. Although it's not really much. And she has pain, and she's B27 positive, but it's chronic, not inflammatory. She's now 47. Can we make a diagnosis out of it? The well, obviously we're clinicians, and therefore we need to take into account what the patient has, yeah, overall when we examine. So this is a patient with a typical very severe scoliosis. That scoliosis puts pressure on that joint. So you see, she has that axis of mechanical loading. When she lies down, that change here is not that prominent, but typically, obviously, the clinical part and the imaging part show us that this is not typical spondyloarthritis, and you remember this is in the front of the joint, it's very little, and it's lesser bright. So we may have also changes like these ones with very little osteitis, some what we call the erosion-like changes. This is more about degeneration in a person who is running marathon. Now, regarding pitfalls in differential diagnosis, you may also consider that there is bone marrow edema in that patient, but there is also a lot of edema in the soft tissue. And that is why, because there is bacterial inflammation, and that bacterial inflammation goes beyond the bone. Yeah? This is after an injection. This is typical bacterial inflammatory findings in a patient with, unfortunately, bacterial inflammation after an injection. And if you now look at these cases, you may see white and black spots, and we need to understand how they look like. So these are, from the top to the bottom, four different patients. Patient number 1 has that lesion here that is not visible or very roughly visible on T1. This lesion is very far away from the joint. It's a single lesion. It's well preserved, its margin. This is a typical cyst. Yeah, it's filled with water. The third patient, let's move over, has also one single such lesion. It's in the middle of the joint, unfortunately, and it's also very close to it, but it's also very round-shaped. It's not the way I showed you that the lesions may look like. They go from the top to the bottom, and it's also black on T1. That's also a cyst. It's empty. One round-shaped thing doesn't do anything. Yeah? If we look at that black part here, which is white down below, you remember T1 is able to find fat, which is black or normal in steer. So that must be fat. It's a fat island or fat cyst or whatever you call it. It's a little bit further away from the joint, also just one single lesion. Yeah, it doesn't really do much. And those lesions here on the right, on the fourth patient, they are many. They're white on steer, black on T1. So they seem to be inflammatory. But they're also far away from the joint. It's here where we have the cerebrospinal fluid. It's very far to the back. And these are, again, multiple of them, not connected to the joint. This is typical for metastasis. Yeah. Now looking at the spine, what we're looking at is not this here. This is a typical line of the vessels. We're looking at the edges, you remember. This is typical spondyloarthritis. The edges are having hyperintense signal. It might be not that easy to differentiate because it's really small sometimes, but as long as the edges are involved, anterior part, posterior part, of course together with the symptoms, this looks like spondyloarthritis. Here you see that those lesions here are also black on T1. And the typical other finding of bone marrow edema that has nothing to do with SPA is where you have not only the edema, but also no disc anymore. Now, this is a very advanced, very severe case of a typical osteochondrosis. It is also erosive. You see here there are some erosions. More important for me here is to show you that the pattern of the edema is important. So the osteochondrotic edema is really going alongside the end plate. The spondyloarthritis edema is staying at the edge. So this is really affecting the entire segment with or without, in that case with, degeneration of the disc. And that is a typical osteochondrosis with erosion. Yeah? The spondyloarthritis patient would have those findings here, or maybe like a triangle, not like a line. And you may have a patient who has both. Yeah? He has degenerative changes and also spondylitic lesions. Yeah, that is SPA-like. This is the reason for having back pain now with the osteochondrosis as a finding. Yeah? And the spinal bacterial inflammation looks like the one that I showed you before for the sacroiliac joint. You have the edema, it really goes away from the bone, and it affects the entire soft tissue. This is after surgery. Now, very briefly, I don't want to confuse you, but just so you get a feeling of how these lesions look like. Here we have the modic lesion again. There is a large lesion going alongside the end plate, and the disc is not well preserved anymore. Here you have a spondylodiscitis after bacterial inflammation. You have the spondylitis and the discitis together, and it's also erosive. Yeah, it's destroying the bone. Here you have what you would call the Anderson lesion. The Anderson lesion is in the beginning of spondyloarthritis, where the cartilage of the disc is degenerated and some part of the disc is going into the bone. Yeah, it's a fracture, in fact. Why is that white? Because here we have some reaction of the bone to the loss of the disc. And this is a typical Scheuermann's disease, where you have edema, typically in the thoracic spine, but it's not that much in the edges. It's the opposite of spondyloarthritis. It is in the bone. Yeah. So I try to put this here in especially those two, in a drawing. Here is the disc, and you see that in spondylodiscitis you also have this inflammation around the disc, and in the Anderson lesion you don't have any inflammation. This is called aseptic spondylodiscitis. But just remember, the pattern of inflammation is important. Yeah, I'll skip that one. Now let's come to an end of that part. Here you have a male patient, 32 years old, HLA-B27 positive, and CRP positive. And the father has ankylosing spondylitis. And you find these lesions. Or you find these lesions. That's another slice. Yeah? This or that. Everybody would be keen to say this is typical SPA, because the clinics are okay, the family history is there, the person is young. However, what I don't like in that image is that this edema, again, is too much. We don't see that much edema in the spine of patients with spondyloarthritis. I will give you another hint. You don't need to know it, but at least that you have heard that. Not only the white spots are important, but also the black spots are important. The reference to water, that is inflammation, is the cerebrospinal fluid. This means if I have hyperintense signal, it is as intense in the bone marrow as the water that I have in my body otherwise. If I have hypointense signal, that hypointensity is because this is white, okay? So this means that this cannot be more black than these areas here. And you see that there is some black spots. You see there is darker spots than the water. Again, don't get too much of confusion here, just that you may have heard that. If you see these really very dark or darker, or you can also combine it or compare it with the disc, the darker areas than the disc, and a lot of edema, be aware, although the good radiologists will also tell you this is malignant. Yeah? This is a typical lymphoma. And that patient obviously didn't have many symptoms. If you go and examine the same patient, you see how much of inflammation there is in the spine. Yeah? And you see here those darker areas. Yeah? In any case, what I want to say is that symptoms are important, imaging are important, but sometimes we just cannot get it right, unfortunately. The other thing that you also have to take into account when you see these images yourself is that the typical spondyloarthritis lesions do not run like, let's say, like a line. Yeah? Look at this here. There is hyperintensity, but this is a bit strange because it's really very nicely going along. This is a typical motion artifact of the aortic artery. So this is the aorta. It overlays sometimes the bone, and the MRI is not fast enough to get it. Yeah? That's the same thing like this. Yeah? You have this typical line from the top to the bottom. And why can't we see the blood in the aorta? Because it's too fast for the MRI. Okay, that was the very long, let's say, first part. I have very many slides now to show you, but I would like to show you just a couple of things that are important to me, or I will skip the rest. Okay, and then we will go maybe into one or two cases before we end. Now, we have updated the definitions within ASAS of how to define a typical MRI of patients with spondyloarthritis. And this was published in 2015, 2016, where we said that you have to have edema, but the clinical history also needs to align. Yeah? The typical history and the images together make the diagnosis. And again, this is maybe too easy now after all this whole hour we went through, but I would like to remind you. Hold on. We start with capsulitis, exactly. Capsulitis is increased signal on the water-sensitive images. This is this here. In a very clear steer image, you can also see capsulitis. Usually we see them in the gadolinium-enhanced images. You don't see them on T1. For joint space enhancement, we may indeed see joint space fluid that is more active. That's a sign of activity. That image you see already was done in a specific way without going into details about how that sequence looks like, but just be aware you may also see signal in the joint. That is also a sign of activity. We may see edema around the erosion or without erosion. That doesn't matter. We may see some enthesitis. You remember the small enthesitis I showed you before. This is more at the areas where the enthesis is coming in, here, there, or maybe even here or here. That's another image of a joint space fluid. The fat is defined as homogeneous, hyper-intense signal on T1. You don't need to see a lot on STIR. It doesn't really have to be deep black. It's mainly on T1. So it's homogeneous. It's very well demarcated from the remaining bone marrow, and it's close to the joint, and it is accompanied by erosions, like this. Yeah. We have that sign that people call backfill, or in fact, it is fat within the joint. You see that here. It was not there before. The patient was treated, was doing well, still this occurred, showing that the patient was treated late. Yeah, this will happen anyway. So this is fat within the joint. And the erosions are the typical structural changes where the cartilage is disrupted, or like this one. I don't know how well you can see that on the bright screen. But the cartilage disruption is the typical erosion. Of course, you may also see ankylosis or bone buds like this one or here, yeah? That's, I think, easy for everyone. What we've published is also the findings for the spine, where you have spondylitis posterior, you have spondylitis anterior, you have a lot of it, you have facet joint involvement, so it can really be activity everywhere in the joint, in the bone. You see now the difference between the erosive osteochondrosis that I showed you before and the typical SPA findings. The SPA findings have more triangle form. You see that here. Yeah. The typical osteochondrosis has a more horizontal course. And here a small erosion, although this is something you will not really see that frequently in MRIs or syndesmophytes, although also here MRI is not the best tool for syndesmophytes. Mainly you see them when they are fatty because of the fat that shows them more prominently. One thing that you will see relatively soon coming out as a publication is this one, where we have performed a study and have tried to improve the communication between rheumatologists and radiologists. I know this is small letters, it's not easy to read. You don't have to read it, in fact. It will, again, it will come out as a full publication. These are the other recommendations for how to request, the rheumatologists request an MRI, and how to report back. The radiologist reports back to the rheumatologist. Imaging in patients with suspected access spondyloarthritis. So this is the request. We have 6 points that we would like to always mention when we request an MRI. And the radiologist has more work to do. They have now 11 points that they have to give us back. So that's the information we want to get. That's the information we want to give so that we have an equal and good communication. And the other thing that is also being now written, it's not that far yet, is this ASAS project where we have tried to standardize the imaging protocol. So we recommend from every radiologist at least 4 sequences of the sacroiliac joints. T1 and STEER, or T1 and T2, fat suppressed, semicoronal, plus what we call the erosion-specific sequence. I didn't show this now. You may have heard the VIBE technique. If you haven't heard that, forget it again. We'll discuss it another time. And a semi-axial STEER sequence in order to see the inflammation as well. So it is, in fact, this typical protocol we would request. I've shown you those 3, that one, and that one. Semicoronal, semi-axial, and the VIBE technique or the erosion-specific technique is something that we can discuss another time. So I would like to pause here for a while, and ask you if you have any questions. Or was it too much information? Yes. I will repeat the question after, yeah.
Mainly from the fatty lesion on the corner will appear the syndesmophytes. The idea that I already also showed them a new study that was done, and it was shown that more often it's directly from inflammation toward, and I don't know how, okay. I don't know how strong is the evidence, how you interpret this. Thank you.
Okay, that's an important point if you said it like this. So there are some publications that show that fat, or that the sequence is inflammation, fat, syndesmophyte. And there is a more recent publication that came out just recently. I was part of it, so I do know where the data come from. And there's also other publications that show that fat is not needed. My opinion is that fat is needed. In the publication you may have shown from RMD Open, what we found was that indeed, in the majority of the cases, we had inflammation in the beginning, no fat, but new syndesmophytes. However, what we do not know, and it was discussed in that paper, and it's also the topic of discussion otherwise, these MRIs were done every year or every second year. We do not know if there was new fat developed over time. So we have the baseline MRIs, the 2 years MRIs. At baseline, you have fat and inflammation. And then you see the syndesmophyte at the end. But if that inflammation has developed fat, we don't know in the meantime. That's why we say if you see someone now and has inflammation, the risk for developing syndesmophyte is the same as if that patient has fat after 2 years, because we don't know what's happening in between.
Thank you, because I shown you your work, but I also shown that work, and I was a little bit confused because I saw a lot of experts speaking about it, and I think also the same is my feeling, but I understand better now. Thank you.
Well, we have biopsy data. I didn't show them because it goes beyond the topic, where we have seen that there is a lot of osteoblastic and osteoclastic activity if you have inflammation. If you have fat, in those areas, there is no osteoclastic activity anymore. For some reason, the fat kills the osteoclasts. And you have exceeding new bone formation all of a sudden. The reason why that is, I don't know. We are now investigating this. But there is clear data to show that this sequence is happening. And what we have also shown, there was this study where we took the certolizumab data and we analyzed them over time. And we found that the longer you keep your inflammation, the more probable it is that you get fat. So that not only the occurrence, but also the duration of not treating the patient is important, because then you get your fat and then you get your new bone formation. So early treatment, let's say with any biologic, in that case it was the one, but any treatment is extremely important because then you stop the inflammation early enough, you don't get new fat, and you don't get new bone formation.
Thank you very much.
I would say that if you go at the level of the sacroiliac joint, somehow you can explain the thing that the fat is present, because you have the backfill that looks like fat, because it is fat. It is fat. So you don't have ankylosis without the presence of the backfill before.
Exactly. So we know that if you have backfill, you have much higher chances to get ankylosis. Why? Because that fat obviously creates osteoblastic activity. Okay. Now, what I have done was to prepare some cases. I didn't know if we are able to show it from my computer or we are able to show the slides. I will show you it from the computer a little bit differently. So that is the one. I have different cases here. Hold on, somebody wants to show me some. One thing that we can go through is maybe this one. That is now a patient who has, spondyloarthritis, and what you see is the typical STEER and T1 images with a lot of edema, bilateral, it's clear. I'm showing this in order to show you the other way of looking at images. This is now another patient. I've just took some patients here to demonstrate it, where you have the same is you have a STEER sequence, you have edema here, you have edema here. I don't have the axial images, unfortunately, but you remember, if it is small, if it is in the lower part of the joint and in the anterior part, because this is a bowel, there you would not count it as positive. This is a typical image that I took from a person who is running marathon. Yeah. So the edema is there. It's by far not as much as we saw that before. And there is also small erosion here, you see that. And another typical picture of a patient who has edema also. Hold on, let me check the T1 sequences too. So has edema as well, and the question is, where does that come from? Is this one? So you see, this is sorry. This is more a sign of edema around a vessel. But if you look at that part here, sorry, let me close this one. You see that there is some edema around the capsular area that still shows some osteophytic formation. And that is looking also to the patient. That is a patient who is a hard worker, is working outside, building the streets, having chronic back pain, around 45, but still that edema is more degenerative. Yeah. Why? Again, because you have some blurry image, you have some osteophytes, you have some small erosions, but it is far away from the clear joint. This is more in the anterior part of the joint. This is the bowel. Okay. So you always have to look into this, of course, the symptoms, but also where the edema is, how it looks like, and whether or not, for example, the T1 is giving you some additional information. Now let's go to another case that I believe is interesting for you, and that should be, let me see, that one. So what I'm showing you is now the pictures of a female patient, who has ankylosing spondylitis and came to us because of low back pain in the morning, but also in the afternoon. So it's not only typically when you wake up, but also it's something that you really feel when you really put some pressure on your spine. The sacroiliac joints are clear, there is spondyloarthritis. I will show you the images now of the spine, or maybe we can move them around here. And you have to check if you find something that may be of interest to you in terms of understanding what that patient has. Does she have a worsening of her spondyloarthritis, or does she have degenerative changes, or does she have something else? She was on NSAIDs, and the question is, do you put her now on a biologic? Yeah. Just let it go through once or twice more.
There is a facet joint involvement, I think, in the upper part.
We have many different things.
Yeah, and there is a scoliosis, I think, because you have a different point in the upper part too.
So if we stop here, I will come to what you said in a second. Most of the people who I show these images pay attention to this here. That's nothing. Yeah, we all have that, maybe. It is a typical insertion of the disc. It may hurt a little bit in the beginning, but as you said, the most important finding of this patient is this one. Yeah? So we need to pay attention to what is happening in the entire spine, not the ones that we are more used to. This is a typical facet joint involvement on the one side, but also on the other side. You see that here? Here too. And this is indeed a clear sign of disease activity. So this patient needs treatment. If you don't treat her, she will fuse. Yeah? The other thing that you also need to pay attention to is this one. That's normal. Yeah? This is happening to almost everyone, and you lie on the bench of the MRI for a longer time, and here where you have the lordosis, the vessels come together. Yeah? And when you go walk around, this will go away. So that's totally normal. Yeah? So her problem is the facet joints, indeed. Yeah? Here you see that relatively clearly, the other side as well. And that patient needs clearly treatment. Let's see another patient. And I have to now see if I put everyone correctly in here. No, that's not the one. That's the one. Hold on, I need to find it myself. Exactly. So here we have a clearer picture of what is happening because we have both axial and coronal images. These are both steer sequences, and I'm just playing them through. Oh, we cannot do it in parallel. Let's scroll it like this. You see there is edema in that picture. There is also some strange lesions there. And the question is, what is this edema in a young female person, which is mainly unilateral, and when we see it on the axial picture, we see that in the anterior part. You remember, I also told you about the sclerotic areas that you see mainly in the iliac bone. If we look at the T1 images, one second, T1 is, I believe, yeah, that's the T1 image. If we look at the T1 images, we will see that there is not really much from what I told you. Remember, the fat needs to be around the joint, not far away, and it needs to be more homogeneous, which is not here. Yeah? And there is also sclerosis. And, importantly, the joint lines are very well preserved. So you don't even need an X-ray here to say that this bone marrow edema unilateral in a young woman with a lot of sclerosis and no erosions is osteoarthritis condensans. Yeah? The important thing to remember is that this is indeed a lot of edema, but it's in the very front. Yeah? Here is the bowel. When you go towards the middle of the joint, you lose it. There's almost nothing. But this picture is more impressive because that bubble of edema is large. I don't remember if we have the X-ray here. We don't have that. And maybe another picture that I would like to show you is this one before we close. This is a 40, I think he was 48, a guy that I saw in the outpatient clinic with a diagnosis of peripheral spondyloarthritis. He was on sulfasalazine for many years. And he came after ski vacation. He didn't have any back pain so far. And he developed back pain after his ski vacation. And he went to his rheumatologist. The rheumatologist made an MRI because the diagnosis was there. And he also did a lab test. And the lab test showed high CRP. Relatively high CRP. We have a 0.5 milligrams per deciliter as the cutoff. He was at around 3.6, which is pretty high for spondyloarthritis. So now you see that image of that patient. I go back. So we had to find out what is happening in this case. High CRP, no big triggers of any kind of, let's say, infection before. He came back from ski vacation, maybe he has something degenerative. I can tell you that there was no degeneration. I'm showing you here the T1, or let's say the T1 of the gadolinium. Let's see the T2 images. There was no big signs of degeneration here in the back. He has some osteophytes, but he's okay from his spine, all right? So the question is, it's too small here for me. What does this patient have? The reason to show this MRI is that even in a patient with spondyloarthritis, let's say the diagnosis is correct, I don't know, he came with a diagnosis, that's a different point if you take it away or not. With high CRP, you always have to look around. The problem of that patient is that there is an asymmetry in this picture. And that asymmetry is here, that part and that part. Yeah. So you see that although he has the disease, he may also have some other things, like that part here, this one, which is all white with some white spots in it. And the problem here was that he had an accident when he was skiing. He didn't even say that in the beginning. He has a hematoma. And this hematoma has become an abscess within the iliac muscle. So you don't need to know that as a rheumatologist. I just want to say, don't always look at the sacroiliac joints. There's a lot of things around, and we need to take care of them. So it is, you remember, in the spine, the facet joints, here in the sacroiliac joints is a muscle around, maybe also in a bacterial inflammation, the soft tissue edema, and so on. So that patient has now undergone surgery, he is fine, but the problem was a different one. If you give now here a different treatment, you will miss it. Okay, I think we come to the end because we only have 8 minutes left. Thank you.